Hello, everyone, and welcome back to the Empowered Cancer Patient Podcast. Today, I am honored to speak to Dr. Robyn Roth. Dr. Roth is the Boobie Doc, and she is absolutely fascinating in terms of all the things that she has experienced and the knowledge that she's obtained, as well as all the things that she is doing to help empower and educate her patients and her followers. So, without further ado, here's Dr. Robyn Roth. Hi, Robyn.
Hi, thank you so much for having me in that beautiful introduction.
Oh my goodness, it's my pleasure, actually. I've been watching you for a while. I was actually
Oh,
afraid to ask you to come onto my podcast. I was
are
like,
you
would she come
kidding?
on my podcast?
Oh
You've
my
done so many
God.
great things on Instagram.
Thank you. It's so much fun. I feel like I was looking for a creative outlet and a way to reach a larger population of people that need this breast health information.
Yeah,
And what better way than social media?
I know. It's really become like the Wild West is now starting to be reined in
Yeah.
by real doctors like us. Here we are actually trying to tell some truth out there.
Exactly. I think that all the misinformation that swirls online is the reason I decided to get online in the first place. I always joke that the boobfluencer life, I didn't choose it, it chose me because I was so frustrated as a breast radiologist seeing all the lies about mammograms and using it to sell other alternatives which are not safe and effective and proven to work. So it
Right.
was it was kind of like I needed to put my voice out there to give, like you said, another trusted resource.
That's wonderful, actually. And we're going to get into
Thank
some
you.
of those myths very soon.
Yeah.
But why don't you
Mhm.
start by just telling us, how did you become the Boobie Doc?
So it's actually the Boobie Docs plural, and there's a story behind there because it
Yeah.
always is, right? So let's see, where do I start the story? So when I take you back, when I was younger, I loved writing. I thought I wanted to go to college at the University of Florida. I grew up in South Florida. I thought I wanted to go
Mhm.
to college for journalism, and at at orientation, they were like, "Who wants to raise your?" They were trying to prove to us that all of us were going to get weeded out, and none of us were going to become doctors. And apparently, I like a challenge because they're like, "Who of you is actually going to be who thinks that they're going to be a doctor?" And everyone raises their hand, and I'm like, I raise my hand, and my dad's like, "What do you mean you want to be a doctor?" And when I thought about it, I when I was younger, I had growth hormone deficiency. And I had to take growth hormone every day, like kind of in my middle school years, kind of my transformational years.
Mm.
So I knew I thought I wanted to help kids, and somehow I made it through med school. And when I was in med school, I chose radiology because I really I thought I wanted to help kids, but then I realized that they were too sick or they're too well, and you're dealing with their parents most of the time.
This
And I
is
was really drawn to so true.
true.
Now that I'm a parent, I get it, right? Um, but I went to radiology because I was like, I'm very empathetic, and I felt like I was taking a lot of this stuff home for me from my patients.
Mm.
So I felt like I needed to be one level removed from direct patient care. So that's why I kind of went into radiology. And then breast radiology, when I was in radiology residency, my cousins were both diagnosed with breast cancer
Oh,
in
wow.
their 30s. And their story is something very similar to what we hear a lot of times out as breast cancer doctors. A 30-year-old comes in with a lump. It looks like a fibroadenoma on ultrasound. She's told it's probably benign. Let's follow it.
Mhm.
She pushed for the biopsy. It ended up being triple negative breast cancer, and she ended up being BRCA1 positive. Um, and then her sister, who was 30, she was 32 at the time. And then her sister was a little bit older, and she had breast cancer. She was 35
Oh, wow.
and found to be BRCA. So that's kind of how I landed in breast radiology and then became so passionate about helping women, number one. Um, and then somewhere like I love my role as a breast radiologist. I
Mm.
mean, I'm the one who's interpreting all the breast imaging, but oftentimes I'm giving bad news. I'm doing the biopsies and I'm giving bad news. And I think I got a little burnt out a few years in, and I really missed, like I felt like I had 3 kids in a short amount of time. I lost who I was, and I felt like I lost my voice and my spark.
Mm.
And so I knew I wanted to write, and I was like struggling. Was I a mom? Was I a doctor? I started as Dr. Robyn Roth, but really couldn't find my voice on Instagram. And then it was like one late night breastfeeding during the COVID pandemic when I realized I was like literally surrounded by boobs all day.
You were
And
literally
it hit
what?
me.
Oh, surrounded by
Surrounded by
boobs.
boobs all day.
Okay.
Yeah, like I'm a at work, I see them. I was
Right.
breastfeeding. I had 3 young kids. And I was like, I'm a boobie doc. And I changed my name to the Boobie Doc. Well, I say plural, it's Boobie Docs because I work with my best friend from day one of med school, Adrian.
Uh-huh.
And I was like, we should make it the Boobie Docs, and we'll be two best friends who talk about, who work
Okay.
together. Um, and that lasted for about a year. But that's when we kind of got really popular and I found my voice.
Hmm.
But then she hated social media, so she left. But I kept it just in case she ever comes back.
Okay. Very
So
cool.
that's the Boobie Docs.
And there it is. So is Adrian also a breast radiologist? Oh, wow.
Yep, she's my best friend from day one of med school, and we work together at the same clinic as breast
Now, what
radiologists.
hospital are you at? Where-
So I'm at Cooper University Hospital.
Uh-huh.
It's in South Jersey, right outside of Philly.
Nice.
We're affiliated with MD Anderson Cancer
Oh, okay.
Center, so we follow the MD Anderson Cancer Center
Well,
protocols.
that's very interesting. Having been, originally from
Mhm.
Memorial Sloan Kettering, how did MD Anderson all the way over in Texas reach over to South Jersey and Sloan didn't get you guys? Like, that's interesting.
I know. Well, I don't know, but it's been a great partnership.
Good.
Like I really just love using, having that the whole cancer team and the
Right.
protocols are really important. And I think that's for anyone listening that's going through breast cancer, I think it is really important to find a cancer center
Hmm.
near you that people trust.
Yeah. No, I agree with you. And even if,
Hmm.
not to knock, you know, community physicians and doctors that are not affiliated with cancer centers, I do think it's always a good idea for patients to at least have a check-in with an
Hmm.
academic center to make sure that they
Yeah.
are getting the state of the art or they are being offered the best clinical trials that are available that sometimes if you're not affiliated with a big academic center you might not have access to. So I have had in
Hmm.
the past many patients, for example, that have had, would come to me say every 3 months just to check in. Here's my scan, here's my
Hmm.
blood work. And I would, coordinate with the other doctor who didn't necessarily need my advice necessarily. Some
Hmm.
would, some wouldn't, but that it just
Yeah.
gave the patient also just that second check. And it's always nice to have a second set of eyes because there are things that they'll see and things that I'll see that, the other one didn't. But um,
Absolutely.
so tell me a little bit about being a breast radiologist. What is your day like in the clinic? What do you do? So you actually do look
Yeah.
at boobs all day, but
I do look at boobs all day. Follow me for more life hacks.
touch them too, right?
Right. Yeah. Well, so I'm the one. So as a breast radiologist, I'm the doctor who's interpreting all of your breast imaging, your
Right.
mammograms, your ultrasounds, your MRIs.
Right.
Um, I'm not the person performing the mammogram or the ultrasound or the MRI. Those are the technologists, and
Hmm.
they're a really important part of the team
Sure.
too. But so I'm also the doctor that you would meet if any of those tests were abnormal. So if you had to come back for a diagnostic mammogram or an ultrasound or even a biopsy, I
Right.
would be the doctor you would be meeting. Um, so I think a lot of people think that radiologists sit in their dark room all day, and that could not be further from the truth. As a
Right.
breast radiologist, I'm actually helping women and men in their most vulnerable, like they're coming
Right.
to me, they think they might have cancer.
Yep.
So I'm doing the biopsy, and then in many cases, I'm the first doctor that's giving them the results of cancer.
Hmm.
So it's funny how in this because I thought I wanted to be like a step away from patient care, yet I'm
Right.
so involved in patient care. But I always like to like I giving the news is such life-changing information, so I try to be compassionate and take my
Of
time
course.
and
Of
really
course.
help them get their breast cancer team together. I try to
Right.
give them the positives, that it's very treatable, was caught early, and, now we're gonna help you get the best breast cancer team available, which includes a breast surgeon like yourself, maybe an
I'm a
oncologist.
med-onc. I'm actually the
Oh,
med-onc.
you're med-onc. Oh, I thought you
I'm
were a
med-onc.
surgeon.
Yeah.
Med-onc.
No.
Okay, so
Yep.
even also important, surgeon,
Yeah.
med-onc,
Right.
and radiation oncologist. So I love and I always say, next time I see you, you're gonna have beat it, and you're gonna be on the other side of this.
Mm.
So
Has anybody ever come back to you and say that that didn't happen?
yeah, I think for the most part, I know that breast cancer diagnosis is a lifetime of it's a
Yeah.
right.
Yeah.
It's survivorship is this whole other complex time.
Yeah.
There's never but I do think that when they come back to me in their first postoperative imaging,
Hmm.
they I get the biggest hugs, and
Sure.
yeah,
Sure.
that's the best part of the job.
And then, so you actually will then, you're part of a multidisciplinary team. So most of
Yes.
our audience probably understand that, but the breast cancer, sort of spectrum includes, the breast radiologist who diagnoses and who may be doing the first biopsies, for example. We have the breast surgeon who will be doing the removal of either the tumor itself or the entire breast. We have a plastic surgeon in case there's reconstruction that needs to be done. We have a breast medical oncologist, which is me. I always like to call myself the point guard, of course, but because we sort of once everybody else has done their job, we end up still kind of being one of the guys that have to keep making sure everything is going in the right direction. But there's a breast surgeon, there's a breast medical oncologist, and who did I forget? The breast radiation oncologist as well. So in case the patient is going to need some radiation. So there's, a whole cast of characters that work together very closely.
If you're the point guard, what is the radiologist? Like, am I the drafting? Like, do I draft the team? I'm the general manager.
I don't know.
I don't know. I think the surgeon's a quarterback.
Okay.
Is that a big statement? Is that controversial?
Well, I guess the thing is that if you get a diagnosis of breast cancer, they start with you, right? And then in almost every circumstance, they're going to see me at some point. Even if I say no hormone therapy or no chemotherapy, what have you, they're going to see that, because nobody's going to want to take that on themselves without have a medical oncologist involved. And then the surgeon, once they've done their surgery, I know that the patient follows with them, but unless there's a recurrence or a complication, they usually follow with the med-onc the longest. But I guess they are still also seeing the radiologist as well. I guess the thing is that a lot of times, and this might be very regional or local relevance, but I feel like a lot of times the patient, when they go back for their repeat imaging, don't always see the same breast radiologist like they would the same medical oncologist,
Right. No, right. It's more like staffing. But I do have some patients that will ask for me and make sure I'm there I know, which is such a compliment.
Of course.
It feels so good because most people don't know their radiologist, or you met them once when you were diagnosed with breast cancer and you never want to see them again.
Well, and then again, we're talking about the multidisciplinary team. I mean, I would work very closely with our radiologist. There would be many times that I would, they would call me, I'd come over, we'd discuss, we'd decide what to do, or what have you. But so I mean, it's all very important that we coordinate our care together. So
absolutely.
So you do the mammograms, you do the ultrasounds, you do the biopsies, what have you. And so what are some of the more difficult things that happen during your day? So one thing that keeps coming to mind that I hear about all the time in social media and whatnot is this new breast density. So people are now getting a breast density score, and everybody's up in arms about what exactly to do about it. Can you talk on that a little?
Absolutely. Nothing would make me happier. So, your breasts are composed of fat and fibroglandular tissue. And the fibroglandular tissue is a dense breast tissue. It's the stuff where things happen. I like to think of it. It's where all the tissue is active. And so the more active fibroglandular dense breast tissue you have, dense breast tissue appears white on a mammogram, and so do breast cancers. So, so I like to think that it makes it harder to see small breast cancers because it is white and breast cancers are white. So it kind of obscures the underlying breast cancers in some cases. Think of it like finding a snowflake in a blizzard. When there's a lot of snow, it's harder to find a single snowflake. But also we now know that having more active dense breast tissue increases your risk for breast cancer because this is where they develop. So it's a double-edged sword. It makes it harder to find small breast cancers and it increases your risk. 50% of women have dense breast tissue. It's not abnormal, but it's important to know about. And now you do know about it because it's legally, you'll get a letter saying whether if you have dense or not, if your breast tissue is dense or not dense.
Right.
So if you have dense breast tissue, you might want to consider adding a supplemental ultrasound or MRI in addition to your annual mammogram. And that helps us find smaller node-negative cancers that are more treatable.
Right.
I always like to say early detection is the breast protection. Like when we can find it early, when it's localized to the breast, your outcomes are way better. They're still good if it's later, but we want to optimize everything.
Well, let me, if you don't mind, let me just stop you right there because I think that the biggest problem is that you might like to consider adding an ultrasound or an MRI. And I would say the majority of our listeners and patients are, well, of course I want an MRI and an ultrasound. I want everything. Just, make sure that I don't have any cancer. But where is the problem? Because patients aren't able to get that. They can't just request it and somebody gives it to them. It has to be prescribed.
Well, so, it comes down to educating the doctors, the patients themselves to know to ask for it. And, I think more conversations like this bring awareness to what it is and what it means. I would say that supplemental imaging is not for everybody, though. When you talk about, I think my obvious thought is like, if, yes, of course you'd want to find it at the earliest stage, but if you do extra imaging, you're going to find extra things.
Right.
And not all of them are breast cancer. And that's called a false positive.
Right.
So we call you back, it causes anxiety. In some cases, we need to do a biopsy. And again, that causes more anxiety. But most people would take the biopsy, an image guided procedure. It's minimally painful. It's fairly quick, and we get answers. But for some people, they might stick onto that, anxiety that it might have caused when it was unnecessary. So I do think it's a conversation. I don't think it should be like a knee-jerk response to, you have dense breast tissue, so you need to get an ultrasound or an MRI, depending on your risk factors. But I do think it's a conversation. And if you're on the proactive side, certainly consider supplemental imaging. I personally like to stagger it every 6 months. So you're never going more than 6 months without some kind of breast imaging.
No, I agree. But I just think that the barrier to entry for getting an MRI of the breast is pretty high. So even if I said my patient has dense breast tissue, I would like to have, I'd like to order an MRI, probably get rejected, because my understanding is that you have to also have a symptom.
Well, so let's talk about that. So you could know some women can get a breast MRI. If you have a greater than 20% lifetime risk of breast cancer by one of these risk calculators, then you should be eligible for a breast MRI. Talk to your insurance. I would fight that if it's getting denied. But if you don't have that, there's a few options. I do think supplemental ultrasound is a great option. It's more available. And a lot of states are now covering mandatory insurance coverage if you have dense breast tissue. Again, this is something you could push for. But they also have abbreviated breast MRI is often a cheap alternative to whole breast MRI. It's quicker, it's cheaper, and a lot of places will offer it for $199 out of pocket or something.
So what exactly is that?
So abbreviated breast MRI is like, in a normal breast MRI, we give you contrast. It's a magnet. Breast MRI is a very sensitive imaging tool. And, in a perfect world, we would use that on everybody, but resources are limited. It's expensive. It takes a long time. We give you gadolinium contrast, which is a problem if you have underlying kidney disease, but for most people, it's not a problem. Usually when we do a whole breast MRI, it takes about 45 minutes. You're in the magnet. Some people get claustrophobic, but the abbreviated breast MRI is only one sequence of contrast instead of 3 to 4 sequences of contrast. So it's about 15 minutes instead of 45 minutes. But it's a really good alternative to whole breast MRI if you don't meet criteria for that. So you could always look into that. I personally love contrast mammography.
I was going to just ask you about that. I was at a conference recently, and they actually were comparing the sensitivity of CT enhanced, contrast enhanced mammogram versus MRI, and the CT enhanced mammogram is much easier to get, I believe.
Yeah, the contrast. So CT mammogram, CT breast is another thing. So this is a contrast enhanced mammogram. So it's like I like to say it's like a mammogram and an MRI had a baby. It gives you all the advantages of having that IV contrast on board, but it overcomes the breast density because normal breast tissue doesn't always enhance as much as cancers enhance. So it's quick. It takes under 10 minutes. We've been using it at my institution since 2011.
Wow.
And I really think
how do I order that? How do you get that instead of a regular screening mammogram?
So it's not FDA approved to replace an annual screening mammogram yet. I think that's coming down the pipeline. A lot of places don't offer it. So I think utilization is a problem, but there are lots of places. I think more and more places are having it. I would like to see it being used in lieu of a regular mammogram, especially in women with dense breast tissue.
Sure.
Would be the ideal situation to use that.
Yeah. So again, just to for the listeners, just to compare and contrast, we're talking about contrast enhanced mammogram. So the patient would get an IV in their arm that would give them regular contrast, IV contrast, like they use in a CAT scan, right? It's not gadolinium, it's regular contrast. And then they get a routine mammogram, which is often 3D, correct?
Yep. So it's a 3D contrast mammogram.
There you go. 3D contrast mammogram for our listeners, which is different than CT.
I have some breast CT is like a new and evolving technology. The benefit of it is that it doesn't have compression, which some people really are against. I
Hmm.
personally don't understand why we would use that instead of a mammogram, because the mammogram is a lot cheaper, it's quicker, it has less radiation that I know
Sure.
of. It's easy to biopsy. CT, breast CT, aside, it's a whole nother unit. It's a whole nother thing
Right.
to read.
Right.
I don't
Why?
I don't know where it would fit in my clinical practice just yet.
Yeah, I
I'm not on
understand.
board with that yet.
Yeah. So, all right. Well, very interesting. So let's play a little game.
Mhm.
Do you like games?
I love games.
Well, you have kids. You have to like games. So you have
I
to
love it,
at least
yep.
pretend you like to play the games.
Yeah.
All right. This game is called Fact or Fiction. Ready?
Yes.
Okay.
Born
So,
ready.
born ready. She's born ready. Dr. Robyn Roth, the
Yes.
Boobie Docs. All right. Fact or
Mhm.
fiction? You can replace an annual screening mammogram with a thermogram.
No, so therm I wish thermograms would go away. It's like herpes, it just won't go away,
They're like,
right?
what?
Like herpes.
Like, the
You wanted a
thermogram,
viral
you
clip,
heard
there you
that
go.
here. Thermograms are like herpes.
Oh, they won't go away. No, so therm I promised you viral. No. So thermograms are a way to detect inflammation in the breast. There's really no use for it. It's sold by chiropractors and functional medicine doctors as a replacement, even though the FDA has made a statement saying it does not replace mammography, and they will go over any thermography manufacturer or anyone who sells it as such. So no, it does not serve as a replacement. We see so many in my practice. I've seen so many people that were called back from a thermogram. Now they have to get a real mammogram because that's how we're going to get answers. And there's nothing there, and we really don't know what to do with it. Or B, they come to me with a late stage breast cancer, and they're like, I don't know how. I've been getting my annual thermogram, and I'm like, well, who told you to do that? So no, we do not support thermograms around here.
So, do you think there's any role for them? So, say I'm getting my annual mammogram, and and then I go see this doctor, and she's like, "Oh, you should get a thermogram. It'll add to your screening." What do you think about that?
I will
Fact or
absolutely
fiction?
say false, false, false,
False.
false, false.
Fiction.
I got so excited. Fiction. I got so confused. I got too excited. No, thermograms really play no role. Like, unless you really want to see like your inflammation in your body, but like, what is the purpose? That's what they're going to try to sell you so you can get rid of the root cause.
Yeah, yeah. The root
It's
cause.
run
Okay.
away.
So there's
Okay.
another one that's out there. I
Mm.
don't know if you've heard about
Mhm.
this one. They
I'm sure
take
I
your
have.
tears. They take your tears and they run a protein analysis on it, and they use that as a screening for breast cancer. What do you think about that?
I think is it oh wait, is that the saliva? Like, I thought it was, maybe it is tears.
There's one that's
No, it
tears, and they look for proteins in the tears.
right. It's so nonspecific right? Like, it's gonna call a lot of people back, and they're gonna need to get a mammogram. Like, there's no role that really, to find your breast cancer, we need to look at the breasts.
Right. Exactly. I
True?
agree. All right.
Yeah.
Should we do another one? Another fact
Yeah.
or fiction? Let's
Let's
see.
bring it.
Fact or fiction? If you don't have a family history of breast cancer, you're not at risk.
Fiction. False. Right.
Okay.
So most people who are diagnosed with breast cancer don't have a family history or genetic mutation.
Right.
Okay. Having a family history increases your risk by 2 to 4 times, depending on the, in the first, having a family history of breast cancer in first degree relative increases your risk by as much as 2 to 4 times, depending on their age of diagnosis. But not having a family history does not preclude you from getting breast cancer, unfortunately. The two
Right.
greatest risk factors for developing breast cancer are being female and getting older. Wah wah. So we're all at risk for breast cancer. Yeah, so we're all at risk for breast cancer.
Right. Right. Yeah. And the percentages of patients that actually have breast cancer that have a genetic risk at baseline
Mhm.
is very low. It's less than
Yeah, it's
20%.
only it's like 15%.
Yeah,
Right.
exactly. So you could be part of that other 85% and still have a risk and still think that you're not at risk. So make sure
Yeah,
that
everyone has to take their breast health seriously. If you've ever had breasts, then you need to take your breast health seriously.
your breast self, not your best self, your breast
Put your
self.
put your breast self put your breast foot forward.
Okay, let's see. What other things can we talk about? What else is controversial?
You
Okay.
forgot the biggest one. Fact or fiction? Mammograms cause cancer.
Um, eh,
Fiction. Right.
fiction.
Oh, this is the one that got me online and keeps me up at night. Right. So mammograms have a very small amount of radiation because it's an X-ray. A lot of medical imaging has X-rays and uses radiation. When we're comparing about radiation, mammograms have the lowest amount of radiation compared to a number of other studies. Like when you're talking about looking at CT scans, it's 0.3 millisieverts, which means nothing to you, but it's equivalent to about a cross-country flight to LA or 8 weeks of background radiation. So it's a very low amount of radiation. We're exposed to levels of radiation all the time. But the mammogram allows us to see microcalcifications and some of the earliest signs of breast cancer that we really cannot see on ultrasound or MRI or any other imaging test that I'm aware of that people are trying to push for breast cancer screening to replace mammograms. So I do think they play a role. And we always try to keep breast radiation to a minimum, and we only do it when it's necessary. But I do think an annual screening mammogram saves lives.
Absolutely. And somebody else, one of the medical influencers on social media actually made a terrific post about this. Shout out to Dr. Liz O'Riordan. She put out a post that was really well done, looking at the risk of a mammogram causing breast cancer and comparing and contrasting that to the risk of getting breast cancer from drinking a glass of wine every night. And so, I mean, the reality is you have people that are, living their lives and thinking they're living healthy and they have a glass of wine a couple times a week. That wine is about 10 times more likely to cause your breast cancer than a mammogram ever would. And so,
Absolutely.
when you look at people that are trying to make choices on how best to reduce their risk, you really have to look at all of the risks and not just the ones that most convenient to you, like, oh, I'm not getting a mammogram, it's going to cause my breast cancer. Well, okay, don't have a light beer then either.
Absolutely.
So it's an
everything we do
interesting
has a risk, but
Right.
also if you're getting your screening mammograms every year, then we're going to find your breast cancer early. Like that's the whole point. That's why we're here.
Right. Yeah.
So
No, it's true.
when people post that, mammograms cause cancer, they're usually trying to sell you something alternatively that is not going to detect your breast cancer at an early stage. So be wary because I guarantee you most of those people are trying to sell you something.
Yeah. No, it's true. That's very true. So
unfortunately,
let's circle back to you a little bit. So, what was great this year? What happened? What went well for you this year? And what are you most proud of?
Well, let's see. I've been on the news a few times. I was on the news every weekend in October, which is really fun for me.
Wow.
Yeah. So I'm on Good Day
Jealous.
Philadelphia.
Jealous.
You just got to keep hustling, and putting yourself out there. I pitch myself to people. Like I believe that being Delulu is a Salulu. And, if you want it, just keep doing But also, I actually completed my children's book called Everyone Has Boobies. Yay!
Everyone has boobies.
Ain't that the truth? It will come out, and by the time you see this podcast, it comes out January 6th. I am so excited. I literally have been writing poems my whole life, and I joke that this book was written by little Robyn because it really celebrates boobs of all shapes and sizes and teaches kids that you shouldn't be ashamed of breasts. They're parts of our amazing bodies.
That's amazing. I want a copy of that.
You.
That's so
I will give you a signed copy.
Wait,
so you can get it.
Let's see.
Yep. So let me show you. This is more of the official copy that I got from Amazon, which is going to be, so it will be available on Amazon. So it says draft because that's what it is. But so let's take a look inside.
Did you do your own illustrations?
No. Oh God, no, no. I hired an amazing woman from Pakistan who I spoke to her all through, we did all the illustrations through WhatsApp and she literally plucked it from my brain. So last week in class, our teacher said, we have a special guest. The door swung wide, and to our surprise, who walked in? A breast. The class began to chuckle, followed by blank stares. Hey kids, I'm just a boobie. There's no need to be scared. Everyone has boobies. It's pretty plain to see. Everyone has boobies, just like you and me. These are my boobs. Wait, I have to show you. Those are my boobs.
Those are your boobs?
No, these are not my boobs, but I call them my boobs. Wouldn't that be
Horrible.
something? They'd be droopier. Wait, I have to show you this.
How old are your kids? Have your kids approved of this book?
My 11-year-old thinks it's cringy, but I have a 5, 8, and 11. I'm probably not going to be able to read it to any of their classes, but they do think it's cool. Wait, I have to show you this. Oh, these are my kids, by the way. But boobies can get boo-boos and have a scar or two. My mommy's boobies have a scar. My daddy's has one too. But if boobies get a boo-boo, there are things that doctors can do. That's me, by the way.
That's adorable.
They could find it, they can shrink it, they could fry it, they can freeze it, they could cut it, they can cure it, and make that boobie boo-boo go bye, bye, bye.
I love it. I want to frame that.
Oh my God, me too. Yeah, so I'll definitely get you a copy.
This might be my favorite thing ever.
I know. Wait, you have to see this one. It says meet the author, and it goes into my whole bio, and it says she has 2 breasts. So, and then it has some resources. So if your boobie has a boo-boo, here are some resources that can help you.
Oh my God.
So
Robyn, you should be so proud. I'm so excited for you. That is amazing.
Thank you. I'm so
You've got to get on Oprah with that.
I better. Oprah, if you're listening, I would love to come on. I know. I'm sure she listens to the Empowered page.
She does. Hey,
she does. Oprah.
She doesn't yet.
Yeah.
We got other people. We got other people we can put it on.
Yeah. No, I'm so excited about this book. I hope you see this everywhere on your screens. I'm going to try to get on Oprah. I'm going to try to get on the Today Show. So
I love it.
What we're manifesting for 2026.
I love it.
Thank you.
I know somebody at the Today Show. I'll send it to her. I do.
Please. I feel like this is the perfect.
Hasn't helped me yet. Can you get on the Today Show yet? No.
I know. I feel like this is the perfect book to read to Hoda and Chanel. I mean, not Hoda and Chanel, Jenna and Chanel now. I'm very excited.
All right.
Mm-hmm.
Love it. All right, my dear. This has been phenomenal. What an enjoyable conversation. We've shared so much knowledge. We've broken up the myths. We played a nice game of Truth or Dare. Oh no, it was
we should have played Truth or Dare. We'd definitely be showing our boobs by the end of this podcast.
No. I won't be able to post it on YouTube. They'll throw me off.
Oh my, that's true. Oh, don't you mean boob tube? That's my boob tube.
Everyone, please follow at the Boobie Docs. I love it. Oh my God, you got it all. You got all the stuff.
I usually have it behind me, but it blinks, so it's too distracting. So I took it down.
All right, we're going to say goodbye, but to be continued. We'll have to definitely have Dr. Robyn Roth back again. Bye, everyone. Thanks for listening. We'll see you again soon.
Bye.